Hey, Jaime, can you hear me?
Yes, I can hear you. How are you?
Good. I hadn't signed in yet, which is why you couldn't come in. I had signed in on our other commonality account, so it didn't
Okay.
link. You're
Okay.
good. You're good.
Oh, good. I was getting nervous. One thing that I don't have is the Yuan's bio. I have John Brush. So remind me again. So the idea is that you make a quick introduction, then I introduce both speakers, right?
Yeah, I'm just going to welcome everyone to the webinar and pass it right over to you. I thought she shared her bio. Give me one second.
Most because I have John's, but for some reason I
Yeah.
don't have
Okay.
hers.
Okay. Let's
I can send her a text and set for her to send me one, but I wasn't sure whether you have it.
I think she sent it to me.
She sent the photo headshot. That one I have.
Uh, Okay, yeah. Let me see. You're right. She sent her headshot and her title. Um, okay. Okay. When she joins, we'll ask for her bio.
I just sent her a text so she
Okay.
can, yeah.
What's your title again? I always forget. I know it's
Mine?
yeah.
It's a long one. It's SVP and CMO at Strategy and Innovation, United Health Group Strategy and Innovation.
Okay, great. Awesome. Hopefully they'll join soon. I just did the security, so nobody can unmute themselves, start their video, share anything. But we're letting them chat and rename themselves. I'm going to do a waiting room right now,
Okay.
just because that way nobody joins early. Can you text them both and just say that I'll let them in as soon as if you have their phone numbers, if it's easy,
Yes.
don't worry
Yes.
about it. Okay. Okay. Did you have a good weekend?
I did, yes. Oh, so it was a good weekend. How about yours?
It was good. It was good.
I just sent both texts.
Great. And I should be able to see when they sign in, and I'll let them in.
Okay.
What are you doing for the holidays?
I don't think I have any. Do I have any plans? No, I don't think we have plans yet. There are some possibilities, maybe going to Connecticut. Nothing really out of the ordinary. Here's John Brush.
I don't see him yet in here.
I just unmuted him, so it
Oh,
looks
you
like
admitted him too. That's so funny. I don't see him in here though. Oh, whoop, there he is. And let me make him co-host.
yeah, his co-host.
Hey, John, can you hear us?
I can.
Hey,
Great.
John,
Hi, Jaime. Hi,
how are
Jenny.
you?
Good, thank you. How are you?
Very
Very
good.
well.
So, John, just so you know, I'm just going to start the webinar. By the way, we're recording right now, but CDC is going to cut all this out, so this will not be on our public-facing YouTube channel. Our conversation right now, but I'm going to start it. Welcome everyone, and then I'm going to pass it right over to Jaime, and then he will introduce the two of you. So I'm kind of going to be mostly behind the scenes, just doing the tech and stuff for you all to have the conversation. right now I'm allowing people to chat questions. I have the security measure that they're not able to unmute themselves just because we don't want to have a lot of disruption right now. But they should be able to submit their questions in the chat box.
Okay. So I assume I'll share my screen and I'll do the presentation from my screen.
Yeah, yep, you're a co-host, so you should be able to share your screen.
And so we've got a total, counting the title slides, we've got a total of 28 slides. And so I was going to give 1 through 8. Yuan was going to give 9 through 23, and then I'll give 24 through 28.
Okay.
We think it'll be about 30 minutes or so for those slides.
Okay. Normally we do more of a conversation for these fireside chats. So that's fine though, if you want to share, it makes sense because you actually have something to show versus just a conversation. So after your presentation, why don't you test it right now to make sure you can share your screen? You should be able to.
Hello, it seems I cannot start my video. It says, oh, okay, now
You can now.
it works.
Yeah.
Okay, great. Hi, John. Hi, Jaime. Hi, Jenny.
Hey, how are you?
Hi, Yuan.
Good, good.
So can you guys see
Yep.
my screen?
We can see it. It's not in the presentation mode, but we can see it.
How about now?
Now it is. Yep, you're perfect.
Okay.
Yep.
So John, you will be controlling the slides, right? When I
Yes.
present, then I will just tell you like go to the next slide, and so on.
Yeah.
Okay, sounds good.
And Yuan, do you happen to have thank you for sending the CV. Do you have a very short version? I want to make sure you have time for the conference. If I read I mean, no, John, Yuan, I'm sorry.
Yeah.
No, I got yours, John.
Yeah, I think maybe you can just read the first paragraph. That would be great, or just the first couple sentences. I would say I would train as an epidemiologist and implementation scientist, and my work is in the section of cardiovascular disease prevention, digital health, clinical informatics, and trying to use implementation science methods to resolve real-world issue. Maybe that's it. Yeah.
Okay. I think that's pretty much contained the first paragraph, so I can read the first paragraph.
Okay, sounds good.
Great, I got it. And yeah, John, I have yours. And I think that's about it. You did interventional cardiology at Yale, right?
Yeah, I came through before there was an interventional cardiology year, Jaime. That's how old I am. I actually picked it up along the way at NIH and BU.
Oh, okay, got it. Yeah, because when I was there, they had like cardiology, and then you spend either 1 or 2 extra years doing intervention.
The first interventional cardiology fellows at Yale were Tom Clevin and who was it? There were 2 other ones at the same time, and I can't remember their names right now. But yeah, no, it was the year after I left Yale and went to NIH when they started interventional.
Got it.
Ships.
Jaime, don't let that person in yet. If you see that person entering the waiting room, because we haven't started yet.
Okay.
I'm saying Annie can join. Just do a middle.
Okay.
Let's see if she can join just when I kick it off, that I can focus on talking and she can do the tech.
So Yuan, before you got on, I was saying that we had, we maybe 30 minutes of slides, and they said, well, that's not the way they usually do it. It's usually more of a discussion, but because, we have something to present, we have something to explain, it's fine. But do you want us to sort of like quickly go through it so that you've got, that you can turn it into a discussion, or how would you like for us to make it more in keeping with what you're used to?
I mean, I would say I wouldn't start improvising now. I'll just, whatever you prepare, Jenny, we can adjust it. And
yeah, we're fine. That's totally fine. That's perfect.
Okay.
Yeah, we just think like some of the technical detail it would be pretty hard to explain without showing on the slides. You just talk through it. I think talking about the overall picture, the collaboration, and envisioning the next step, that's totally fine, just like talking through it. But if you want to go into the technical detail, or maybe we don't want to go into too much technical, just explain some of the use case. I think having some slides would be helpful, and we can definitely skip some of the slide. We don't have to go through every slide, like just to show some of the idea, show some of the graphics on the slides would be also intuitive to the reader.
And generally, we're going to have people write their questions in the chat. Remind me.
For now, yeah, I have it where they can't unmute themselves. I just think it might be too disruptive, to be honest with you, but they're able to chat in the chat box. So Jaime, I know John sent you some questions to follow up after the presentation. Otherwise, you can check the chat box if you want, and I'll be monitoring it too. Just so you know. Hold on. I don't. I'm just gonna admit everyone well, actually, sorry, I'm thinking out loud here. I'm trying to do tech and talk at the same time, which is obviously not working for me right now.
So I will share my screen after Jaime does the introductions. Is that the way you want to do it?
I'm sorry. Yes. Give me 1 second. Sorry. I'm trying to get Annie into this.
Go ahead, Jenny. And by the way, and John and Yuan. So I'm just going to be really not talk much about the program because I think I'll just say we're excited. It's a new territory, but nothing specific. Just because I think you'll have plenty of time to go through it. So that way, we don't spend another 2 or 3 minutes just talking about the program. So I'll be surprised if I'm brief just on purpose. All right, we're 2 minutes away.
Yep.
Should be fun. We usually have a really active audience.
Yeah.
They're very interesting groups.
This is my business partner who's joining. Hey, Annie, you don't have to be on video. Sorry.
Yeah, no, I know. Okay, so
Thanks, Annie. You can hop off 5 minutes after. I need to kick it off, and I'm afraid if I'm talking to everybody, I won't be able to also emit all, but you can just emit all. But I'm just worried if people are going to sign in after the hour.
I got you. I think it will just let everyone in, but I will double check before I hop off. Like a point is, I think once we admit all, it will just keep letting people in, but I will.
And maybe we just click off the enable waiting room on the security tag. I can probably click that off.
Just why don't you make me a co-host and I'll handle it so you don't. Oh, I am. Okay. I'll handle it so you don't have to worry about it. Just let me know when you plan on starting, and then
well, it's 11. There's people signing in right now. Why don't we let them in? And I'll just say we're going to give it 1 more minute, but we can let them in.
I'm going to mute myself and then I'll start admitting people.
Great. Thanks, Annie. Really appreciate it. Good morning, everyone. Welcome to our fireside chat. We will get started in about 1 more minute as everyone is signing in. Thank you for your patience as we let everyone in from the waiting room. All right. Good morning or good afternoon, depending on where you are. My name is Jenny Bogard, and I am the Executive Director for the National Hypertension Control Roundtable. And I am so incredibly excited to have you all here today. For those who may be joining us for the first time, we do host this series throughout the year on a variety of hot topics. If you want to look back at any of our previous webinars, it's all on our YouTube page, and we'd be delighted for you to click on that and share that with your colleagues. As you noticed when you signed in today, this is also being recorded, and we will be sharing this with everyone who registered, as well as posting it on our page as well. So welcome, happy November. We are delighted today to be joined by our two panelists and our co-chair, where we're going to be talking about revealing regional trends and actionable insights on hypertension by leveraging electronic health records of a large health system. Our very own co-chair, Dr. Jaime Murillo, who is the Senior Vice President and Chief Medical Officer at United Health Group Strategy and Innovation, will be moderating the chat. So with that, Jaime, I'm going to pass it over to you.
Thank you, Jenny. Good morning and good afternoon to everyone. So thank you for joining us. We know that we all have a busy day, and we appreciate you taking the time to join us today. As you know, every time we talk about hypertension and blood pressure control, this is going to be an interesting and different flavor for what you have seen in past Fireside chats. So we're very much looking forward to having our two panelists, Dr. Yuan and Dr. John Brush. Dr. Liu was trained in epidemiology and global health with a focus on cardiovascular disease. She also studied degrees in global health and population at the Harvard School of Public Health. And she works at the intersection of cardiovascular disease prevention, health equity, and digital health using implementation of science methods to resolve real-world issues. And her long-term goal is to improve care, outcomes, and equity on cardiovascular diseases by designing and implementing technology-based interventions. And she's an assistant professor at Yale Medical School, Yale University Health. Dr. John Brush, who I happen to have known for more than 20 years since our times practicing together, is also another esteemed colleague who earned his medical degree from the University of Virginia, and he trained in cardiology at University of Vermont. Yeah, University of Virginia was his medical degree, and then he trained in medicine at Vermont, internal medicine, and then went to Yale for his cardiology training. He also spent 3 years at the National Institute of Health doing research, and has been practicing cardiology for more than 20 years in Norfolk, Virginia. He is a professor of medicine and former head of cardiology at Eastern Virginia Medical School, and is currently the chief research officer for the Central Health, which is a large regional health system, which is the system they're going to talk about today in Virginia and North Carolina. He also authored a book in 2015 called The Science of the Art of Medicine, a guide to medical reasoning, which many medical schools are now using as part of their training as well. And he has served on the board of the American College of Cardiology and some others as well. So we're very excited about the topic, and we looking forward to a conversation. So you'll see initially a presentation of the fantastic work done in collaboration between Yale and Centara. And then we'll have time for us to discuss different topics. Feel free to ask questions, because we intend of this to be a source of new knowledge to you, something to think about what's new in your own spaces. Can you use your electronic health records and come up with this kind of information, and then elicit some questions and answer from our panelists. So welcome both Dr. Brush and Dr. Liu.
Thank you so much, Jaime. It's such a pleasure to be here, and I'm very honored to be presenting today. Can you see my slides okay? I hope they're showing up okay. So we would like to just briefly talk about what we've done. I know that this maybe is a little bit more formal than your usual fireside chat, but there are some things that we really would like to share with you on how we developed this collaboration and some of the things that we found as a result of the collaboration. So, so this is a collaboration between Sentara Health. It's a 12 hospital system that's based in Norfolk, Virginia, and the Yale School of Medicine. And it's just been a wonderful collaboration. Harlan Krumholtz at Yale approached me several years ago and said, look, if we could get up, we could be running on the same common data model, perhaps we could do some really good collaborative research using data. Harlan and another person at Yale created this company, a startup company called Refactor Health, which does the work of taking Epic data and mapping it into a common data model. There are several common data models out there, and the one that we're using is called OMOP. So we were able to map over 12 years of our Epic data into this OMOP common data model. Now, a common data model, what it does is it basically organizes the data. Epic wasn't created with research in mind. It was created in terms of with practice in mind. The OMOP Common Data Model was created by researchers with research in mind. It organizes the table in a harmonized way in very discrete and defined tables. And so we were able to take that data that's been turned into the OMOP platform and place it into a cloud-based data enclave. We're able to give Windows Virtual Desktop access to that enclave to Yale analysts, and that's enabled us to do this collaboration. Ends up, we went up and running on Epic in 2007, so we've got lots of data. In fact, we've got data on about 7.5 million unique individuals. Now, some of those were sort of light touches, like a vaccine or something like that, but we've got data on 3.3 million who have measurements in our measurement table, and about 3.4 million who are patients, unique individuals who are in the visit occurrence table. So we've got big data that we can evaluate, and we've been off and running on that. So this is an example of team science, where we've put together an amazing team. You see Yuan and Harlan Krumholtz and Yintian Liu at Yale. We've got at Sentara, we've got a software engineer and a cloud architect that attends our weekly meetings. We've got me as a content expert for the hypertension project. Yale, as I mentioned, Yuan and Yintian, and we also have Refactor engineers on our weekly call. We have a weekly call every week to keep this project moving forward. And so if there are any problems with the data, or where the data sits, or we can fix it right away because we've got everyone on the call. It's really a wonderful collaboration. So our first use case was to look at hypertension trends and disparities, and we were questioning whether, can you take a large regional health system and leverage its electronic health record to analyze hypertension trends and disparities in a way that might drive improvement? So we had this 1.7 terabyte block of data over 12 years. And what we did first, as our very first study, was we did a serial cross-sectional study. This is quite similar to the NHANES study. Similar to NHANES, we sliced our data into 2-year segments and did a serial cross-sectional study. So when you do a prospective study, you decide on a particular protocol on how you're going to collect data. When you're doing a retrospective study, you also have to decide on a protocol on how you're going to go about analyzing the data. And so one of the first questions is, well, which blood pressure are we going to use? Ends up we had about 134 million blood pressure measurements in our measurement table. And so we started to define our operational definition. So I'm going to turn things over to Yuan now, who will talk about our operational definitions and present to you some of our data.
Thank you, John. Now I'm going to go into a little bit technical details on how we define this operational definition and how we turn big data into actionable insight. So as you can imagine, when a patient comes into a health system to see a doctor, they may come into the health system on different date. And then even on the same day, there may be multiple visits for a single patient. And then even for the same visits, there may be multiple blood pressure measurements. So this graph shows you the hierarchy of blood pressure measurements in the electronic health records. It's quite messy, to be honest, because these people come in different time and they may have different number of date on different number of visits and different number of measurement. So what we do for the data processing is that we, for each visit, we drop the first blood pressure measurement and take the average of the rest of the blood pressure measurement, and then to be the blood pressure for that particular visit. And then we further combine the visit level measurement to take the average, so that each patient on a particular day, they will have one blood pressure measurement. We talk to the clinicians, and we also look at the data to define different operational definitions of it to make sure this is aligned with the clinical practice. And please go to the next slide. So then we end up with 4 different operational definitions. There's no gold standard defined in the guideline, but what we hope is that we can try different operational definitions. If all the different definitions will show consistent result, then we'll add confidence to our finding, right? So let me just go through this one by one. The first definition is looking at one blood pressure measurement greater than 140/90 during the 2-year cycle, or have first-line treatment of blood pressure. And then the second operational definition is to take the first blood pressure measurement. Since we have multiple blood pressure measurements for each visit, we can take the first one and also add the medication to define hypertension. And the third one is to take a random blood pressure measurement out of all the blood pressure measurements for that particular visit, and then combine with the medication to define hypertension. Finally, we use multiple blood pressure measurements. If 2 blood pressure measurements are greater than 140/90 during a 2-year cycle, and they have first-line blood pressure treatment, then these people are considered as hypertension. On the next slide, we're going to show you the finding by applying all these 4 operational definitions. Each of the panels here represent the result applying one of the operational definition. And then this is showing the trends of hypertension prevalence across the 12 years observational time in the Sentara health system. And this is adjusted for population age. You can see there has been an increasing trend of blood pressure prevalence, regardless of what definition we use. Now, of course, when we apply different operational definitions, the absolute number of the prevalence vary, but what we care here is the trends show pretty much consistent. And we also found that the trends are consistent with the National Health and Examination Survey that has been published in the literature. Next slide, please. Besides the overall trends, we also see substantial racial ethnic disparity. So here we stratify the result by 4 different racial ethnic subgroups. We can see the green color here, which represent non-Hispanic Blacks, has substantial higher hypertension prevalence, regardless the definition we use. And this is also consistent with the existing literature. And this is also important in the Sentara catchment area because 30% of the patients in the Sentara health system are considered as non-Hispanic Blacks. Really shows a missed opportunity here for us to improve hypertension management in this subpopulation. Next slide, please. And then we also look at among patients with hypertension, what are the blood pressure control rate? This is the result applying the 4 different definitions. We can see there's some frustration in the blood pressure control rate, but in the recent years, since 2018 and 19, the control rate has been declining, and this is also consistent across different definition use. And then next slide. Then among patients with hypertension, we also see the hypertension coded rate. Previous slide, I think we missed. Yeah, so this is to see how many people actually have a hypertension diagnosed. This has been increasing over time, and this is also consistent across definition. So in this first case, use case of big data in Centura Health System, we leverage EHR from real world setting to get some insight. And we show the national trends are consistent with what we saw in the National Health Examination Survey, but also we found substantial disparity and show distinctive regional demographics. Of course, this finding provide opportunity for improvement with the prevalence increasing, and especially a quarter of these patients are not well controlled. So why do we care about this? You may want to ask. The trends already been shown in the literature in ENHANCE. Why do we care about this? I think the value of this is that it shows the regional experience, and it used the real world data that is almost ready in real time. Like in the national survey, the country are spending millions of dollars sending out coordinators, sending out people to collect this data. However, electronic health record, the data keep growing as people come into the health system. And we are able to show the consistent trends in terms of prevalence and control with using the real world EHR data to show consistent result with the national estimate. So that shows by using the EHR data, we can do more timely analysis and identify gap in intervention, gap in care that we can do timely intervention on. So that linked to our second use case, which is to show the delay in hypertension diagnosis. We all know that timely hypertension diagnosis is critical for effective management and prevention of hypertension complication. As we see in the previous use case, hypertension control is really not optimal at the moment. Less than a half of the patients are not reaching hypertension control. And getting a timely diagnosis is really the first step of it. Next slide, please. Here, using the EHR data, we develop computable diagnosis of hypertension, which is based on 2 consecutive blood pressure reading greater than 140/90. As you can see on this diagram, a patient may have multiple blood pressure measurement in the health system. And then the 2 red dots indicate the blood pressure elevation measurement. If the patient have at least 2 blood pressure elevation, and this is greater than 30 days apart and less than 2 years, we consider this patient have a computable diagnosis of hypertension. And the second date of the second blood pressure elevation is considered as the index blood pressure measurement. Next slide. And what we do here is to compare what the computer could identify patient as hypertension with what is actually documented in the EHR by the physician. So in the electronic health record, the physician documented diagnosis, and we are able to identify those structural diagnoses using concept ID in the OMAP common data model. This is essentially equivalent to the diagnosis code we previously seen. So using this long list of hypertension diagnosis code, we are able to identify who are the people already gotten the diagnosis from the doctor. And then we compare the computed and the structural diagnosis to define what are the time difference between those 2 measures. Next slide, please. Then here we are able to identify 335,000 patients with computable diagnosis. And based on different relationships of the computer diagnosis and structural diagnosis, we further stratify this patient into 4 groups. These include patients with pre-existing diagnosis code. These are patients whose physician diagnosis occurred before their computable diagnosis. And then patient with early diagnosis code. This is where patient got the physician diagnosis after the first blood pressure elevation. And then the eventual diagnosis code, or what we call the delayed diagnosis, is when the structural diagnosis code, which is the green line here, occur after the 2 blood pressure elevation. Finally, there is a group another patient without any structural diagnosis code. And then the pie chart here on the right-hand side shows you the distribution of this patient in each of these 4 groups. I would argue for the patient with delay in hypertension diagnosis, this would be the focus of our analysis. This is the purple group here with 17% of patients in the Sentara health system have eventual or delayed diagnosis group. Next slide, please. So we further look at how long the delay is. We found that it's surprising is more than a year, 631 days in the Sentara health system is the time between the computable diagnosis and the actual diagnosis of hypertension documented in the chart. And then next slide, please. Why do we care about it? It is because this delay in hypertension diagnosis has implication for treatment. If we look at the treatment status of patients in the 4 groups we just identified, excuse me, you can see that patients with pre-existing diagnosis code or early diagnosis code, their treatment rate is pretty high, nearly 80%. However, patients with eventual diagnosis code or delay in hypertension diagnosis, excuse me, their treatment rate is 36%. Also, the treatment rate for people without any structural diagnosis code is low, it's 27%. So having a diagnosis, timely diagnosis, does have implication for prescription or treatment for hypertension. Next slide, please. And then besides the treatment status, there's also implication for adverse cardiovascular events. Since Sentara data have 12 years follow-up of this patient, we are able to look at cardiovascular event rate in the next 5 years after patient with delay in hypertension diagnosis. And we specifically focus on 3 different outcomes, including acute myocardial infarction, heart failure, and cerebral infarction. And we also created a composite CVD outcome for combination of all 3 sub-outcomes. So we can see that here, again, stratified by the 4 groups we just defined, people with eventual diagnosis code or the delay in hypertension diagnosis code, denoted in the green color here, has the highest cardiovascular event rate. Remember in the previous slide, they have a lowest, not the lowest, but substantially lower treatment rate compared to those with early diagnosis or pre-existing diagnosis. Now, besides that, the low treatment rate, they also have a higher event rate. Next slide, please. In summary, this study really highlight a concerning delay in hypertension diagnosis, and this delay has impact on the timely intervention and complication prevention. And by leveraging electronic health data, health system like Sentara can identify area for improvement and also improve the efficiency for hypertension diagnosis, ultimately can improve patient outcome. So next, I will turn over to John to summarize what will be the next step and insight from this.
So we're very happy about where we've gone in less than a year. This has been this work has been less than a year, and we've been able to accomplish a lot. Next, we want to start to look at social determinants of health, and to do that, as you all know, social determinants of health aren't currently regularly reported in the electronic health record. So we're in the process of geocoding all of our patients in our common data model enclave, so that we can apply the social vulnerability index to each one of our patients, and to start to determine whether we can find social determinants that might explain some of the disparities that we see in hypertension. We're looking at other uses in maternal fetal medicine, obesity, diabetes, and we're looking for ways that we can turn these insights into action. So and this is an example of how we're doing this. And we've got this, big data approach, but we also have sort of a boots on the ground approach. We were recently awarded a grant from PCORI, and our share of that was $3.4 million over the next 5 years. And this is with Yale, Mass General, Houston Methodist, and Sentara. We were able to build this on top of our community outreach program that we already have here at Sentara. So we are identifying vulnerable populations pockets of vulnerable populations within our treatment areas so that we can really zero in and try to reach out. And so this grant is meant to improve hypertension control in vulnerable populations. And the question that is being asked is whether remote blood pressure monitoring plus by itself or plus the use of community health workers, whether those two interventions will improve the control of hypertension in vulnerable populations. So we are actually recruiting patients through community-based organizations. And in our area, the community-based organizations that we are going to be using to recruit patients is African-American churches. I was just visiting one this morning. I visited 10 churches. And so we're going to sign up 10 churches, African-American churches in our area as recruiting sites and as collaborators in this initiative, trying to improve blood pressure care in vulnerable populations. We're going to convene a community advisory board who are church leaders and community leaders and a patient. And all of this will launch after the first of the year. Actually, the beginning of recruitment will begin on March 1st. So we're very excited about our sort of a combined program of where we're gaining insights through data. And so we're, in summary, we've been able to leverage our real world data to create a very agile data platform, develop an incredibly collaborative team science approach. We're coming up with some actionable insights, and we're very excited that this is just the beginning, and there's lots to come. So we'll stop there, and we can open it up for questions. And I really appreciate everybody's attention. Thank you so much.
Well, thank you both for what you can see now is the opportunity to, one, not have to depend on remote historical data, and secondly, create a more dynamic approach to be more real time. And I'm going to ask a question about that came from the audience. And then more importantly is, what are the actions that we can really learn from these experiences? Because I think most of the time we tend to have an idea what our populations is doing in terms of blood pressure control. But then when you look at the data, all of a sudden it's like, wait, we're actually not as good as we thought. That's the usual real world experience. So I actually appreciate your candid approach and showing, hey, we're not perfect. Here's the data, but because now that we have data that is actionable, we're going to make a difference. And so I can't wait to see the next phase of this process. So congratulations to both of you. All right, so I'm going to start with some questions that came from the chat box. Feel free to put your questions over there, and we'll work on those. One is Yuan, you were talking about the different blood pressure level at different points and so on. What do you do when you had 2 or 3 different blood pressure? Did you average them? Do you use the highest one? What was your approach?
Yeah, thank you for the question. This is actually a very good question. We try different approach. So first, we take a look at the data to see whether the first one is actually substantial different than the others. And we define the first blood pressure measurement is significantly higher than the rest of them. We talked to the clinician and they said that makes sense because many of the patients, when they come to the clinic, there's not enough time for them to take a rest and stay and get the blood pressure measured. So oftentimes the first one is much higher than the other one. So that's why we drop the first one and take the average of the rest. We also try take the median or look at using the maximum value across all those, using the minimum value across those, and really conduct different sensitivity analysis. As you can imagine, the actual value for using different operational definition, the prevalence is going to be different, but we see a consistent trend across time, no matter which definition we use. So I think the short answer is yes, we try different operational definition, and we not focus on the absolute value, the detail of it, but we looking at the consistent trends across different operational definitions.
Thank you, Yuan. Another question for you as well is, for both. What is that when you say real time, what exactly means that real time? One of the persons attending this mentioned that in their experience, converting native to OMAP data takes time. So they're asking whether real-time analysis is feasible. What's your answer?
Yeah, so we get the data out of Clarity. And so, Epic has a production environment called Chronicles, but each night data is sent from Chronicles to a static database called Clarity. And so that's a 24-hour delay automatically. But there are several steps in doing the refining of the data and putting it and mapping it into the OMAP platform. And so far we've been doing it sort of in batches, and so every several months we will update the data. It comes back to us as a file, and that goes through a quality assurance step, and then it's sent to our ingestion team, and then it's put up into our electronic data platform. So so there has been several months. So it's not immediate real time, but we can make that shorter, but it's certainly much more real time than doing a large study and then turning that around. We're looking at data to the end of 2022 now. And so, but we could actually update that to. I take that back. We're looking up to data to about the middle of 2023 now, and so it's very recent, and it's recent enough that it's actionable.
Great, excellent, thank you. Alrighty, let's jump. Yvonne, we have you there. You put a question, but you have access to the microphone, so please. Oh, by the way, Jenny, I don't want to make it. Should I make an announcement? No, we have Yvonne here. We'll make an official announcement later. But go ahead, Yvonne, with your question.
Okay, thank you so much. First of all, wonderful presentation. It's great to see an example of how the data can be examined regionally. So I was curious about the delay in hypertension diagnosis and whether you plan to or have already examined disparities in delay in diagnosis, and building on that, are you also looking at treatment intensification and any disparities there?
You want to take that, Yuan, or?
Yes, because Sentara Health System, as we mentioned, there's 30% of patients are African American. So looking at racial ethnic disparity is one of the focus across all the use case we have. We did look at racial ethnic disparity in terms of the delay in hypertension diagnosis. And we do find that like minority population, African American and Hispanics, they have a longer delay compared to non-Hispanic white patient. And then we also, treatment intensification is also part of our plan. Right now, we're looking at the number and the class of medication using OMAP ID and clean up the medication data. We're able to look at the number and class of medication. And then just by looking at the treatment status, we see not much racial ethnic difference. Actually, African American actually have a higher prescription rate compared to the other subgroups. We haven't looked at the intensification yet, but just the overall treatment rate is a little bit higher in African American. And I think that's consistent with the national estimate as well. Besides the higher, it could be because like some of the potential reason could be because the blood pressure level in African American is higher. They also have more comorbidity than the other. Then that's why they have a higher treatment rate. But irrespective of the higher treatment rate, their control rate of blood pressure is substantially lower. So that I think that's why we starting to look into social determinant of health as our next use case, is that we believe that many of these social environmental factors could contributing to the racial ethnic disparity in the hypertension control.
Great, thank you for that question, for that answer. It just made me think about how we tend to have this idea in our brain that people who are not controlled, people who are not taking medications, and actually there's a large number of people who, and you showed that in our data, in your data, that there's a fair number of people who are actually on medication but not well controlled because the intensification process has been very unsuccessful, if we can call it that way, or is unfortunately subject to clinical inertia, patients not showing up, or for whatever factor. So that's a piece that we sometimes don't focus enough on, which is where's the real opportunity? I think you can argue that we have two large opportunities: those who are, or three, those who are not being diagnosed. We show some of them. Those who have been diagnosed but not treated, or those who actually have been diagnosed and treated but not intensified in a way that achieve control. So it's good for us to start thinking about those pockets of your data are clearly showing us those trends. And speaking of race and ethnicity, how does your data compare to what you saw in Haynes distribution?
One thing that's quite different from NHCR is the prevalence of African Americans in our population is 30%, which is twice as many as the estimates in NHCR. So we're going to get different results because we have a higher percentage of our population is African American. And sure enough, that results in prevalence of hypertension being higher in our area. The control rates may be lower in our area. The delays may be longer in our area because of the disparities that we see in African Americans. So we're going to go to work on that, with our study, where we're going to reach out to African American churches and try to find those people in vulnerable pockets of our population. We're going to really try to understand that. We're going to try to understand it also, try to unravel this whole thing about social determinants of health. I'm convinced that, there are answers there, but it's like a knot that we just haven't quite figured out which of the strings to pull on to loosen this knot, and if we just go in and start tugging on things, we won't necessarily do good work. But if we examine the knot, first of all, and figure out how we can address it, then we can untie this knot. And so I'm really looking forward to doing that, both at the big data level. We're going to be able to identify right down to the census tract, what their average social determinants of health by census tract. We're going to apply those as proxy values to individuals and to try to make correlations. But we're also, through our community health workers in the other study, going into homes, we're going to actually do questionnaires there. So we're going to be actually questioning about the social determinants of health. So in two ways, we're going to be really addressing the social determinants of health issue. And I hope that we'll be able to gain some insights there that will drive further improvement.
Thank you, John. I'm going to play the role of a journalist here. So you're advocating for ideally using regional data as opposed to NHCR as a way to design your treatment approach?
Yeah, so NHCR is a very valuable study. I mean, we've gotten a lot of insights from NHCR, and so, but this is complementary to NHCR, and I think different regional health systems in different regions of the country may have different considerations than the national averages and the national estimates from NHCR. NHCR has been enormously helpful, and all of us, point to that to try to estimate what are, many of the prevalences and trends that we know are occurring nationwide. But I do think that there is a role for looking at regional health systems. And by the way, the regional health system could be the entity that acts on the data, right? And so if it motivates us to act on our own data, then we've achieved something. And I'm hopeful that it will be more impactful because it's local.
Great, thank you. We have more questions from the audience, but I can see Dr. Wright in showing that in camera, and I know you always have your brain ready to poke and ask more questions.
That's really scary, Jaime. We know each other too well. I will gush over this presentation. Thank you, Yuan and John. You're just doing brilliant work, and we look forward to learning from you and with you. I see Hattie already raised one question I had, which is, and you mentioned it, thinking about hypertensive disorders of pregnancy and how we can learn more quickly how to impact those rates. Thank you, Hattie. My other question smacks of, this is all fine, but what have you done for me lately? I'm just asking if you're thinking about measuring time to control, from diagnosis to control. We all have seen tremendous inertia. We understand some of the factors that lend itself, poor measurement, measuring in the office, not trusting it, etc. So just wondering if you're thinking in terms of that for a future project. And again, thank you for this amazing work.
We are going to thank you, Janet, and it's good to see you. And thank you for those questions. We are developing a very good collaboration with our maternal fetal medicine colleagues, and looking at hypertension disorders in pregnancy is very definitely something that we have in our plans. So we will definitely be doing that. And so in terms of the delays, every piece of data in OMOP is time-stamped. And it's very easy to look at, trends and activity over time. So we will be able to do that for sure. We've already looked at the delays between the computable diagnosis and the coded diagnosis, but now we'll be able to look at, the actual blood pressures and we'll also we could start to look at correlations between medications added over time and effect over time. So our platform, our data platform, it enables us, it's so agile, it enables us to just, if you think about a project like that, you think about a question like that, we turn that around very, very quickly. A week later, we'll talk about that in one meeting, and then Yuan and her team will come back a week later, and that the answer will be there. It's just been phenomenal.
Yeah, I think that the infrastructure we have right here is really powerful, and the pipeline we're doing is using hypertension as use case, but really can be extendable for other chronic conditions such as diabetes and so on. I think the hypertensive during pregnancy issue is really our next step. I see the U.S. Preventive Service Task Force just published a scientific statement on the screening of hypertensive disorder during pregnancy. And using the platform and the pipeline we have, we can easily extend the use case right now to look at the screening rate of hypertension during pregnancy, and hopefully could provide some insight into for clinical practice as well.
And how wonderful that the population that you're looking at has a high prevalence of African American adults, and so we may be able to make more headway faster through the insights you can offer.
That's right. Yep.
And John, is that part of your scope now that you have contact with those 10 churches and have community involved? Is there's a purposeful approach to include pregnancy or hypertension sort of pregnancy into this program?
It's definitely on the drawing board for the big data approach, the big data analytics. I mean, and it really is going to be very easy to address. It's not one of the our involvement with the community based organizations, the African American churches, that relates to the PCORI grant that we have, and so that's going to be a little bit more narrowly focused for that particular effort. But it's definitely going to be a focus area in our big data approach for sure.
Great. And then speaking of the PCORI grant, we don't know the details, but someone in the audience was asking the role of community health workers, pharmacists. Any thoughts?
Yeah, so it'll be testing remote blood pressure monitoring, and so we are going to be. And so, who does the monitoring? Those blood pressures will flow from a Bluetooth-enabled blood pressure cuff in the patient's home to a hub that transmits the blood pressure to Epic and flows into flow sheets. And then we at our place, we're going to have a nurse practitioner that's monitoring that, but other places they're using clinical pharmacists. But having sort of team-based care to evaluate those blood pressures and to respond to those blood pressures when they're remotely measured and then fed into the system. And then, so that's step one, but then step two will be the addition of community health workers. That's going to be a very interesting part of this, getting people out there in their homes, hopefully increasing engagement, maybe noticing things about, diet and activity that might be helpful in terms of coaching and what have you. So that's the second phase of that PCORI grant that we're going to be doing. Erica Spatz and Rafael Perez Escamillo are the two PIs, the central PIs on that at Yale. And we've been just thrilled to be able to work with that group of people on that second project.
Thank you. Great. That sounds like a lot of great work ahead. Fantastic. There's another question from the audience. This might be for Yuan. For geocoding patients, how do you think you'll deal with patients that are more transient, especially an issue with this population is high risk?
So we're going to use the last address that they have, but that's an interesting question. I mean, I suppose we could look at people who have had multiple addresses, but based on the last address in the record, we're going to use that and geocode that into a census tract level. And so you've heard the saying, zip code is more indicative than genetic code for people's outcomes. Well, a zip code is a large geographic area, postal code, but census tracts are very small divisions of counties. And there's 60 census tracts in Norfolk, 100 census tracts in Virginia Beach. It's a very small neighborhood. And neighborhoods are pretty homogeneous, all right? We live in a segregated society, and within neighborhoods are very homogeneous. And so the values that we can get from the CDC and the Census Bureau about social determinants by census tract are going to be pretty good proxy values to the actual values that a patient may give us. And so I think we're going to have a rich opportunity to compare those determinants, starting with this social vulnerability index, but the 4 themes for the social vulnerability index and the various components of social vulnerability index. We'll be able to make some correlations with outcomes among hypertensive patients and among other target populations as well.
Yeah, and also I want to add something to it is that the census tract information we link with the social determinant of health right now is from the CDC social vulnerability index. And this index is calculated based on American Community Survey from 2006 to 2020. So it's 5-year data. So far, the index does not change over time. So we just have one point in time measure. So as John said, we use the latest address of each patient to link it to there. If there's an update in the social vulnerability index, we can also explore the possibility for using to see how the change in address could be linked into change in social vulnerability index. And right now, the population we focus on is more focused on people with regular access and into the health system, so they have regularly, multiple observations in the health system, multiple encounters. It's not just like randomly stop by in the health system. Then we will have more stable estimate for the result. Yeah.
Thank you. Jenny, you had a question, please go ahead.
So thank you both for this wonderful presentation. I have a slightly different question than some of the other participants in this fireside chat, but John, from a healthcare system perspective, how are you able to get internal approval to focus on this? And then also, what kind of lessons learned have you acquired over the years for any of us who represent healthcare systems or community organizations working with healthcare systems that you can share with us?
That's a great question. How do you get a health system focused on this? How do you get a health system interested in research? That's kind of my job. I'm the chief research officer for Centera, And it's challenging because health systems, they've got a lot to worry about now. Finances haven't, gotten sort of back on the ground after COVID disrupted things. And, they're thinking about a lot of other things other than research right now. But we were able to convince them that, if we're going to do research, we ought to focus on our strengths. We've got patients and we've got data. And so we're expanding our clinical trials because of that strength. But we do have data. And so outcomes research is really an opportunity for us to do some really good research. And I think that we've been able to convince them. We were able to get some local funding to enable us to pay for converting the data into the platform. The health system takes care of the hosting and computing costs of running the platform. And our IT team has just been incredibly collaborative. They're just amazing. I love those guys. And so that's been really, really helpful. I was able to get a local philanthropist to help, also help pay for some of the time of the folks at Yale. And so, we were able to just cobble together a number of different resources from a number of different places. And fortunately, we were able to do this. My boss happens to be someone who's been interested in hypertension before he became our chief clinical executive. And so that helped as well. Getting the buy-in of the C-suite is going to be very important for trying to use big data analytics like this. And I'm hoping that we can make a case that it was worth the investment. It's been a relatively modest investment, I have to say, but I'm hoping we can make a case that it's worth the investment.
Right. Thank you, Jerry, for that question. And actually tagging along that question, I think you asked it in a different way, but it's the same, is what would you do different now that you've done this work? What you said, based on what we learned for the next iteration of this project, I would have done this, or we will do this that we didn't do the first time.
We've worked really collaboratively and iteratively and carefully, and we meet at the minimum once a week, but some weeks we'll meet twice a week. We've done a lot of discussion and a lot of planning, and because of that, I don't think we've made too many, I don't think we've gone down too many, sort of dead ends that we've had to, back out of. Yuan, what do you think? I mean, I'm pretty happy with how this is. I mean, I'm actually thrilled at how this has gone so far. So I can't think of anything that we would have done differently, Jaime, to tell you the truth. Yuan, what do you think?
Right, I agree. I mean, we started the collaboration actually just a little bit a year ago. It's not too long ago, just a little bit more than a year. But I think we accomplished quite a lot. But still, it's the beginning of the journey. There's so much need to be done down the road. As John mentioned, the advantage in our group is really multidisciplinary. Like we have clinician, we have IT expert, we have data analysts, epidemiologists, and we meet frequently. So if we find any error or any mistake or anything that doesn't work, the turnaround time is quick. So that's why we often learn lesson, but we iteratively improve it. That's the model I like. Is really rapidly evolving over time.
Excellent. Well, that in itself is a lesson for the rest of us, which is multidisciplinary, frequent conversations, exchanges of ideas, and so on. So that's detailed planning and execution, of course, are the key. So congratulations on that work. That's absolutely amazing. What are you going to do with this data, John? In terms of you have a population, you showed the control rates are less than ideal, that are not moving in the right direction, that there is a significant health equity, significant disparity that needs to be resolved. What are you going to do with that? Is that part of your selling case? How are you going to tell people we got some work to do? And what be the response not only at C-suite but also the doctors who are doing this day in and day out?
So actually, by this Friday, we should have the geocoding done. And once the geocoding is done and that's loaded, it's in QA now, and so it's being put into the platform. Once that's in the platform, we're going to be able to attach all the social determinants of health code, that's linked by the geocode, by the census tract level. And that's going to open up this whole new area of inquiry. And so that's going to be sort of our next thing. But we've got one IRB approved project with our maternal fetal health people looking at social determinants that will predict stillbirths. That's going to be one of the next ones. We're actually going to use, we're going to start getting our own Centera analytics people involved on that one. So we're going to try to spread the skill set to do the analytics locally. And then, once we start to look at the social determinants of health related to hypertension outcomes, diabetes is going to be next, obesity is going to be next. We're going to be looking at some of these other chronic diseases where social determinants may be the key to that will lead to actionable insights. It will tell us how, as a regional health system, we can start to address those social determinants.
Fantastic. I mean, that sounds very promising. Thank you for that. Such an amazing work. Dr. Wright, do you have any, we have 3 minutes left. Want to make sure, no, you're good. Okay. As Jenny mentioned, well, I put the suspense and then Jenny solved it. You have Dr. Yvonne Commodore Mensa, who will be our next co-chair for 24-25. So very much looking forward to with you, Yvonne, and I'll have the privilege of working with you next year. And Jenny, our superb, excellent director, will guide us through, of course, with the work that we do with Janet and team and CDC and the CDC Foundation. Very grateful to everyone for your participation. Those who maybe there were some specific questions on the technical side that we didn't get to, feel free to connect directly with Dr. Liu and Dr. Brush. I'm sure they will be happy to answer those questions. But we are very appreciative of your presence, your attention, and to both of you for sharing that with us. And hopefully this will open the eyes and more ideas for all of us who are really committed to doing this work of controlling blood pressure with equity. Jenny, I'll let you close.
I just think this was a fantastic fireside chat. Thank you to John and Yuan for presenting and sharing your data. You are doing incredibly amazing work. You can see the comments in the chat box and the emojis that are happening on everyone's screens, but thank you both so much. Jaime, as always, thank you for your continued support and guidance as one of our co-chairs. We will be sharing this recording link on our YouTube page, as well as sending out an email to everyone who registered. So thank you again, and look for some information on future fireside chats from us in our newsletters. But I hope everybody has a wonderful week. Thank you so much for joining.
Thank you very much. Really appreciate it.
Thank you.